Bismillah ar-Rahman ar-Rahim. Hello everyone. Firstly, I would like to thank the scientific committee of the conference about inviting me to participate on this conference as a keynote speaker. I would like to also to thank Dr. Abdurrauf Al-Manama about his sincere guidance and involving me in this important topic related to malnutrition in Gaza Strip after the war. Finally, my name is Mohammed Ilulu. I am head of the Clinical Nutrition Department at Al-Azhar University of Gaza. My topic of interest is nutrition in emergency. I will discuss community-based management of acute malnutrition during Gaza war. In the first section of this topic, we will shed light on the infant and young child feeding, the program that protects many infants and young children from malnutrition during the famine time. Actually, we have some of indicators here. In IYCF, we should focus here about the importance of breastfeeding, specifically in the first 6 months of life after the delivery. The first one is timely initiation of breastfeeding in children aged from 0 to 23 months, meaning the children aged 0 to less than 24 months. That means this is very important of us to have to focus on the breastfeeding during the famine. Many mothers have completed breastfeeding more than 24 months because we don't have enough food. So mothers have protected their children from malnutrition. Actually, the mother have received malnutrition and have received thinning and loss of weight, but actually the mothers have paid more attention about their children on how to protect them from malnutrition by completing the breastfeeding. The second indicator of the IYCF is the exclusive breastfeeding for children and for infants under 6 months. That means no other food can be added for the children at this period. And the third one is the predominant breastfeeding under 6 months. That means some of infants have received breastfeeding and have received from commercial formulas, feeding from the commercial formulas, have a mixed breastfeeding with the artificial feeding. And the fourth one is continued breastfeeding at 1 year in children aged 12 to 15 months. That means we cannot move to weaning the children completely to have a full weaning from the breastfeeding, which is a very important part here in famine in Gaza during famine, because this have protected many children from malnutrition. This is very important also to make a link between mothers and the children. The second part of the IYCF indicators, the first one is continued breastfeeding at 2 years in children 20 to 23 months. In fact, many mothers have continued breastfeeding and returned back after complete and full weaning for their children because they have a lack of resources regarding the foods or have a poor ability to reach their nutrient needs. In addition to that, introduction of solid, semi-solid or soft food in infants aged 6 to 8 months, which is the first part of weaning. That means the breastfeeding alone in this period is not enough to reach our nutrition needs for the infants. So it is very important to have starting solids or semi-solids food to satisfy the children in their nutrition needs and to reach their amounts of food that may satisfy their hungers. The third one is consumptions of iron-rich or iron-fortified food in children aged 6 to 23 months, and the last one, bottle feeding in children aged 0 to 23 months, which is completely not good in this part, in this condition, because bottle feeding can results in some of poor consequences for the children, and minimize the link between the mother and the child. Actually, we should focus here about the breastfeeding, about starting the solid and semi-solid food after the 6 months, and focusing on the iron-rich food and iron-fortified food to manage and minimize the prevalence of the iron deficiency anemia, or to nutritional anemia in general.
In the second section of this presentation, we will focus on the CMAM, the Community-Based Management of Acute Malnutrition, the program that helped the management for the children and the pregnant women, as well as lactating women from malnutrition, using the mid-upper arm circumference, the MWAC, as main indicator.
What are the forms of malnutrition in children? Actually, we can define the malnutrition according to different aspects, but the first one is the subclinical undernutrition. We can categorize it as underweight, which can be defined as or known as acute or chronic malnutrition, can be measured by weight for age. And the second one is the stunting. Stunting can be defined or known as a chronic undernutrition, which is measured by the height for age. And the last one of the phases of the malnutrition in general is the wasting, which is the acute malnutrition or acute undernutrition, which is defined and measured by the weight for height, which is the Z score that we are focusing in the moderate acute malnutrition, the MAM, and the severe acute malnutrition, the SAM. Now we should discuss the first feature of the acute malnutrition, which is the moderate acute malnutrition, MAM, where it can be defined as low weight for height or lengths, less than -2 to more than -3 standard deviation, which is the Z score, a median of WHO child growth standard, or can be measured by the mid-upper arm circumference, that means the MWAC, between 115 to 125 millimeter, and no edema. A child have a good appetite and be alert and clinical well. Actually, if we want to define the Z score and the MWAC, the mid upper arm circumference, both of them can define the moderate acute malnutrition, but actually due to emergency cases we can use the MWAC, the mid upper arm circumference, because we have large numbers and we have limited resources to reach the Z score by measuring and by weighing the child, and having the sometimes difficulties to have available length board. But now we can use the mid upper arm circumference, which is measured easily from the olecranon to acromion end. The last one, which is the severe acute malnutrition, very limited, very low weight for height or lengths, less than -3 standard deviation of median Z score of WHO child growth standard, or we can use instead of this the MWAC less than 115 milliliter and sometimes we can have complication of bilateral beating edema, a grade 1, a grade 2, and a grade 3 based on the location of the beating edema in the feet, in the lower limbs, or in the generalized body. But actually, if we want to use the Z-score, we should completely follow up the children with the Z-score. If we want to use the MWAC, we should completely follow up the children by the MWAC, not with this with Z-score. We cannot mix between of them. The first part that used to diagnose the children with the malnutrition, we should use in all of follow-up. What are the components of the CMAM? The first one is the community outreach, screening children using the MWAC. The first here is regular mass screening, active case finding, referral to treatment sites, and follow-up of the defaulters. Due to poor security and poor transportation in the Gaza Strip, many families cannot reach the facility of the treatment. So the outreach can help manage and find the defaulters and find some cases of malnutrition. This is very important part of the CMAM protocol and for the CMAM management. Active finding of cases. Actually, the MWAC can help all persons on how to find the persons who have receiving poor attention from the community or from the health providers. So the first part of management of the CMAM is the community outreach. The second part is the outpatient therapeutic program OTP for the SAM without complication. We should focus here. The SAM without complication. The SAM with complication should be moved and should be referred to the stabilization center. The admission criteria for the SAM without complication here is the MWAC less than 11.5 centimeters or weight to height Z-score less than -3, no edema or having edema in the first or the second part, a child is clinically well with appetite. Here the condition used for the children between 6 months to less than 5 years. How can we deal with these parts on these children who have severe acute malnutrition? The treatment by using the ready-to-use therapeutic food RUTF, which is plumpinut, 2 sachets per day, and routine medication using in the first week of the after the admission amoxicillin, and in the second week using albendazole for deworming, using vitamin A except in case of edema because it may have toxicity for the liver. Use ready to use complementary food, the mixed fruits and vegetables for children who were between 6 to 24 months. So this is very important. All children from 6 to 5 years should have ready to use therapeutic food. All children between 6 months to 2 years should use the ready-to-use complementary food in addition to ready-to-use therapeutic food RUTF. If any child has a complication, we should refer this child to the inpatient care or to the stabilization center, who can manage or who can be sent to the admission criteria of the stabilization center for the children between 6 months to less than 5 years. For the SAM with complication, what are the complications such as anorexia, severe infection, severe dehydration, hypoglycemia, hypothermia, pneumonia, sepsis, shock, severe edema in the third grade? How can we manage these cases? By the treatment, we need 7 days in the first phase in the stabilization. We can use the formula F75. F75 can provide 75 kilocalories and 0.9 gram of protein per 100 ml of the milk. And after that we can move to the transition phase. Also, this is inpatient as the first phase, which is inpatient. We can use here the F100 formula. F100 formula can provide 100 kilocalories and 2.9 grams of protein per 100 ml, and or ready to use therapeutic food. One of them is enough, but we can use the both of them depending on the case, depending on the situation and the clinical situation of the child. And the third one and the second phase, depending on the how as the child received the treatment, how the child received the attention. Actually, we can use here the 100 formula, or we can use or the ready to use therapeutic food, which actually this is a rehabilitation, which is very important to use ready to use therapeutic food to completely manage after that by ready to use therapeutic food. The main disadvantage of the ready to use therapeutic food is the diarrhea, but actually we can manage the diarrhea in case of the other reasons that affect the child to have the diarrhea. But in case of the diarrhea results from the use of RUTF, we can use the RUTF in separate times a day, not to use as a one meal or such of that, because one sachet of the RUTF can provide about 500 kilocalories, and the two sachets can provide about 1000 kilocalories, which is very important as in famine we have very limited food sources that to satisfy the need of the children. The fourth part of the CMAM is supplementary feeding program, the management of MAM. Here is the admission criteria for the MAM. The MWAC is between 11.5 to 12.4 centimeters, or we can use the z-score of weight to height between less than -3 to more than or equal -3. No complication here. We can use the RUTF 1 sachets per day for children less than 5 years. We can use also 3 jars per day of the RUCF, the ready to use complementary food, and we can use the fortified blended food like super cereal plus, which is very important to manage malnutrition among women who were pregnant or lactating, that can take by the woman herself or by their children, or can be used for all family members to manage malnutrition. Here is the discharging criteria. If the MWAC reaches more than or equal 12.5 centimeters, continued for 2 consecutive visits, no edema for 2 weeks, and the key monitoring indicators: a curing rate more than 75%, default rate less than 15%, death rate less than 10%, non-response rate can be managed accordingly. Average length of stay and average weight gain target more than 8 grams per kilograms a day. That means the children have received a good discharging criteria and good monitoring indicators. Here is the end of this presentation. I wish if I have successfully explained the situation of malnutrition in Gaza during war. Thank you very much and goodbye.